Non-communicable diseases are very much common in this present era, and the rate at which people are coming down with this condition is really alarming, especially in developing country like ours in Nigeria. So it becomes very important that our healthcare workers at all levels, especially community health workers who are at the community to work with those people and ensure that their care are actually optimal. And having understanding that these community workers live with those people in the community, they are the first responders. As such, having a good knowledge of this condition is imperative for effective screening, diagnosis, management, and follow-up care. So that is why it is important we look at these non-communicable diseases. And today we'll be talking about asthma. Asthma is a chronic respiratory condition that is known by that quality of inflammation and narrowing of the airways, which leads to difficulty in breathing. So in this section, we're going to look at this condition, the signs and symptoms, the pathophysiology, the management approach. Then we're also going to look at the anatomical workup of the respiratory structures so that we will have a good understanding of what we're talking about. The process of inspiration, also known as breathing in, and expiration, also known as breathing out, are vital for providing oxygen to tissues and removing carbon dioxide from the body. Inspiration occurs through an active contraction of muscles, such as the diaphragm. Look at this diaphragm. This is the diaphragm. It's a dumbbell-shaped structure that is very, very important in breathing. That is why when someone comes out with a condition as Guillain-Barré syndrome, the person might have issues with a phrenic nerve and might have issues with breathing and might require mechanical support for the person to breathe. So this is the process of inspiration. The gas moves into the nasal cavity to the trachea to the lungs. You see the downward movement of the diaphragm. Whereas during expiration, the diaphragm moves upward to reduce the volume of the lungs so that the pressure in the lungs will be higher than the pressure outside so that the air can be moved out. This obeys the Boyle's law, okay? The same way, in inspiration, the diaphragm moves downward, allowing a larger cavity, decreasing the pressure so that the pressure outside will be higher so that air can be forced down into the thoracic cavity, more precisely the lungs. During breathing, contraction and relaxation of the muscles acts to change the volume of the thoracic cavity. As the thoracic cavity and the lungs move together, this changes the volume of the lungs, in turn, changing the pressure inside the lungs. So what we're trying to talk about is that during breathing, the contraction and relaxation of those muscles, like we said earlier, acts to change the volume of the thoracic cavity. That's what we said earlier. If you look at here, as this dumbbell shape or the diaphragm goes downwards, the volume is expanded. As it goes upward, the volume is what reduced. So that's what we're trying to explain here, that as the thoracic cavity and the lungs move together, this changes the volume of the lungs, in turn, changing the pressure inside the lungs. And this change in pressure is important for inflow of air and outflow of air, also known as inspiration and expiration. Now, when the volume of the thoracic cavity decreases, the volume of the lung decreases, and the pressure within the lungs increase, like we explained. When the volume of the thoracic cavity increases, the volume of the lungs increases, and the pressure within the lungs decreases. As such, the pressure outside will now be higher than the one inside the lungs. As such, air will now flow inside. Let's watch. This is the mechanism of breathing. This is breathe out, breathe in, breathe out, breathe out, breathe in. So as these muscles and the ribs are moving, it decreases and increases the thoracic cavity. Look at here now. It has decreased the thoracic cavity. As such, air is being forced out of the lungs. So that is it. Now let's look at the upper respiratory structure. This is known as the upper respiratory structure. That is the structures of the respiratory system that starts from the mouth. This is a nasal cavity. This is the nose. This is a nasal cavity. This is the trachea, the first section of the trachea. This is the spine. This is the bones of the face. Now, this is where the larynx is found. And these are first part of the respiratory system. And different type of disease conditions affect this part of the respiratory structure. A normal lungs and trachea is like this. You see the lumen of the trachea is wide open, very hollow, which allows air to flow in. But for whatever reason, like we see in asthma, this particular hole is reduced. The person begins to manifest with signs of breath sounds. The person might begin to have wheezy and all of that sounds we hear in disease state of the respiratory structure. So, but in a normal person, in a healthy person, this structure is usually hollow, allowing for maximum airflow, inflow, and outflow as the thoracic cavity decreases and increases. So look at the normal healthy lungs. Look at the colon. Look at the cartilages. This is the lungs. This is the trachea, and this is the diaphragm. That muscle that's responsible for respiration. Now, another important structure is the pleural cavity and the pleural membrane. It is a sac that contains the lungs. This particular cavity contains and allows the lungs to move freely without having friction with the rib structure or the thoracic structure, so that one can breathe in. And there's a fluid that is helping it to achieve this aim, so that there will not be any friction within the thoracic structures and the expanding and contracting lungs. What happens when a person breathes? When we breathe in, the air travels through our windpipe, also known as the trachea, into our lungs. In the lungs, there are smaller tubes called the bronchioles and tiny air sacs called alveoli. In the lungs, there are smaller tubes called bronchioles and tiny air space called alveoli. So when we breathe in, also known as inhalation, the smaller airways known as the bronchioles and the alveoli widen to take in more air. However, the larger airways known as the bronchi narrow to push down the air into the lungs. So that's what happens when there's that expansion and contraction. When the thoracic cavity reduces by way of contraction, like we saw earlier, the smaller airways contract, while the wider airways, known as the trachea and the bronchi, open up, allowing air to actually leave the lungs and the respiratory system. But in inspiration, the larger airways contract, so that the trachea, they contract, they reduce their lumen. the bronchi also reduce their lumen, whereas the smaller airway, not the bronchi and the alveoli, widen so that they can accommodate air because the pressure inside is now lower. Air can now enter from the outside. Breathing out or exhalation. During this phase of breathing, the smaller airways contract, pushing the air out of the lungs, while the larger airways widen to allow the air to flow out easily. However, disease process occurs when something disrupts this process and thus making the smaller or larger airways not to work properly. And as such, you begin to hear sounds as the person breathes. This can be due to conditions that make the airways either stiff or less flexible, so that when there's fluid accumulation or when the muscles are not too tight or as a result of paralysis. So these are things that can actually lead to having these signs. This is a patient. She's asthmatic. What is asthma? Asthma is the most common lower airway disease in children, which results, that doesn't mean it also occurs in adults anyway, which results in diffuse bronchial obstruction. At that point, the bronchi tree, that is the trachea and the bronchi, gets obstructed and gets inflamed. The inflammation is somehow related to genetic and being hypersensitive to certain substances. That hypersensitivity leads to overreaction of the muscles of the bronchi, the trachea, and the smaller respiratory structures, making their muscles to contract and secrete lots of secretions. As such, accumulating that wide lumen we earlier saw. There are many causes of lower airways disease. However, our focus is on asthma. Lower airways disease often result in airway obstruction. That's just it. And which is easily identified by cough, wheezy, or crackle, and sputum products. So in diagnosis of lower air diseases, airway-related diseases, the patient must present with cough, with wheezy or crackle, with or without wheezy or crackle, and sputum production. Once the patient presents, your mindset will begin to work on that this is lower respiratory tract infections, which can be asthma, can be pneumonia, can be bronchitis, can be any of those lower respiratory diseases. The term lower respiratory tract infection is often used to mean bronchitis, bronchiolitis, pneumonia, or any combination of these three, but not limited to that. Remember, our focus is on asthma, but we're trying to give an overview of lower respiratory tract infections. Now, look at this structure here. Look at this structure. This is what really happens when a patient is having asthma. This is that lumen we saw earlier that was very open before now. This lumen that was very open before now is now occluded with secretions and mucus. Asthma is a chronic inflammatory disorder of the airways, which many cells and cellular elements play a role. It is chronic in nature, and it is associated with hyper-responsiveness that leads to recurrent episode of what? Wheezy, breathlessness, chest tightness, and coughing, particularly at night and in early morning. So that is when it's mostly experienced. These episodes are usually associated with widespread but variable airflow obstructions within the lung that is often reversible, either spontaneously or with treatment. So at times, asthmatic attacks on their own resolve, but in most cases, it requires drug. So when it's at this point, the air entering the lungs is now reduced. The person will be gasping for air and having breathlessness and coughing because this is blocking and irritating the respiratory structure. The person will now be coughing and having breathlessness. So when drugs are given, it opens up this occluded lumen. So that is what. So the cause of asthma is the reduction in the size of the opening in this lumen. And this lumen is found in this trachea, bronchi, and the smaller bronchi. That's supposed to be very wide open, but is now reduced because of that allergy and hypersensitivity that led these muscles to contract and mucus now blocking this opening. Look at a normal trachea. See how wide it is. This is a normal trachea, a healthy trachea. Look at how open it is. But in the other one, you see it is occluded, almost closed. So the person will not be gasping for air. He needs to breathe in, need to leave. But here, it is wide open. So these muscles are what actually got irritated and as a way of either as a defense mechanism, now decided to block up. These muscles now build up here to reduce this size of this lumen to that which we saw now, to do to this point. Signs and symptoms of asthma. One is wheezing. Wheezing is a high-pitched whistling sound that occurs when breathing, particularly during exhalation. It is caused by the constriction of the airways and is a common indicator of asthma. You'll be hearing as the person breathes because the air, it occurs more during exhalation when the person wants to breathe out. Normally, remember we said that when you want to breathe out, the larger airways does what? Opens up, whereas the smaller airways contrast to force air out. But because in this condition, the larger airways are now tightened up, the air that is being forced out of the lungs is finding it difficult to leave, and you begin to hear the sound from the person as the air is trying to leave from the already expanded larger airways. Another symptom is shortness of breath. Individuals who have this condition experience difficulty with breathing, especially during exercise. This symptom may manifest as feeling of tightness in the chest. So the person, because the person is already having enough air, the person will now be trying to breathe. He's not getting enough air, and that is not shortness of breath. The person will try to breathe more faster. Another symptom is coughing. The coughing can be persistent and may worsen at night or early in the morning. The individual may have a dry cough or may produce sputum, particularly during exercise or exposure to cold air or any other allergy. So because when the person is not exposed to that particular allergy, the body begins to react to that allergy as a way of defense mechanism, produce mucus secretions and contractions of the respiratory structure. Another symptom is chest tightness. The individual may experience feeling of tightness or pressure in the chest, which can be uncomfortable for the patient. Then increased mucus production. This mucus blocks the airways and can lead to productive cough. The person also may have difficulty in sleeping because as the person, if it happens in the night, as the person is coughing, wheezing, and having shortness of breath, the person cannot sleep very well. Then rapid breathing. because the person is actually not having enough breath, the person will continue to breathe in order to get enough air. Then fatigue, the person will actually get tired and have a reduced activity. What are the triggers to asthma? We have allergies such as pollen, mud, pet, dander, dust mites, and certain foods, which can irritate them. It has the genetic component. Then we also have irritants. So I have irritants such as tobacco smoke, bad odors, air pollution, chemical fumes. Then weather conditions such as the cold air, humidity, changes in weather can also trigger it. Then exercise. Physical activity may induce bronchoconstriction, especially either in cold air or dry air. Then lastly, another trigger is respiratory infections. You know, viral infections like the avian flu or any other flu can aggravate asthmatics because any disease, in fact, any disease that affects the normal function of the lungs, the trachea, the bronchi, and the bronchioles, which can lead to immunologic response, can lead to asthmatic attack. Asthma management. Asthma can be managed with pharmacologic agents, although some can still resolve on their own spontaneously. It is useful to teach patients the concept of preventer, also known as anti-inflammatory, and the reliever for the asthmatic treatment, because this is a non-communicable disease. The patient has a role to play in the management of his condition. So it's always advised to teach them to understand, because most times when these cases are happening, they happen in the night or early hours of the morning. So you should be able to teach them, let them understand this so that they can comply. With the preventer drugs or anti-inflammatory agents, these are medications that are given to prevent an attack from occurring, and they are usually directed towards the underlying abnormalities in the bronchial tree. And one of the drugs used is the inhaled corticosteroids known as beclomethasone. There are many of them, budesonide and all of them, that are inhaled corticosteroids. Another drug that is used for during this preventer or anti-inflammatory is oral prednisolone, which is mainly for exacerbations. And although before you give, you already have given inhaled corticosteroids and bronchodilators. Remember, bronchodilators are important because the actual physiology occurs mainly in the bronchi, the bigger airways. Another group of drugs that can be used is leukotriene antagonists. Leukotriene antagonists such as the montelukast. There are newer drugs that can be used also to during preventer or anti-inflammatory management of asthma. Another thing these patients are reliever drugs or bronchodilators. These are mainly to relieve patients from an attack. When the patient is already having an attack, episodes of attack, these drugs are mainly used. The bronchodilators usually employed are beta-2 adrenoceptor agonists. Beta-2 adrenoceptor agonists are employed in order to achieve this. Thank you.